Facebook Live. It's Tuesday. Is it Tuesday? Or it is Tuesday. I've got the right day. I think it's 7 o'clock. I've got the right time. And that. Oh, and the mic's over here. I knew there was something. Right. Wow. This is the way forward. Let it be known that I've been doing this for ages, and this is the way forward. This sort of virtual. Don't have to touch anyone. Don't have to go anywhere near anyone. Virtual consultations. This is the way forward. You know, ask questions, get them answered, get on with your day. Stay at home. Don't even have to come out of your house. I'm ahead of the game. I'm a trailblazer. I always knew it. So this is interesting times we are living in. Interesting times we are living in. So first question, what do you think the first question is about? Any guesses? Anyone? You got it. Coronavirus. I was asked a question last week. Someone said something about, in fact, I've got the questions from last week. What was it? Someone said something about coronavirus. Oh, no, I think it was in the chat, actually. I think they asked it live. They asked about how do you think coronavirus will affect surgery? And I thought, what are they talking about? I was thinking, how can it affect us? It might affect the NHS, it might affect airline travel, but it's not going to affect us. What a difference a week. Was that a week ago? What a difference a week makes. Whoa. So this is the question I've had this week. I have booked this surgery so this patient's having a facelift and a neck lift or something up in Warrington. So not with me, but I booked this surgery for mid-April in Warrington. My question is, whilst coronavirus has started to sweep through the UK, would it be sensible to cancel it? So I had someone in the clinic the other day who's booked for surgery soon, next week, I think. And she was asking, she wasn't asking, she was just saying what's going to happen. And you know what? God, I know as much as you do. We're looking at the government website. We're looking at the NHS website. I would say daily, but it's actually several times a day because it's changing all the time. So as it stands right this second, well, I say this second, I haven't checked it in the last, maybe I should have checked it before I came on. Well, as it stands, the surgery is still going ahead. We did an operating list this afternoon. And so surgery is going ahead at the hospitals. The risk of contamination, they're not sort of, the flow of patients into private hospitals is a lot more controlled than the NHS, because obviously private hospitals don't have an A&E, so you can't just walk in. All the admissions to private hospitals are planned and elective, so they can control it a bit more. They're not taking coronavirus patients into the private hospitals at the moment. They're talking about NHS getting completely rammed and using private hospital beds and using hotels and goodness knows what. So they're talking about these things, but they're not using them at the moment, because obviously if that happened, then things would change significantly. They're talking about use of resources. They're talking about stopping elective surgery, as in planned surgery, as in all this sort of stuff. So whether things change tomorrow, the next day, next week, I don't know. But as it stands today, things are going ahead. So to the patient who spoke to me the other day, who said, what's going to happen? I'm like, well, at the moment, we're still doing operations. To this patient who's saying they've got surgery booked in April, would it be sensible to cancel it? Difficult question, because what I would say is, and what I always say to people who are having surgery with us, is that, I mean, it is elective surgery. It is planned surgery. You can have it any time. It's not like you've got you have got appendicitis and you've got to have it done now. It's planned surgery. So if you don't feel comfortable, so there's obviously two sides to the story. Either we'll cancel it or you might cancel it, sort of thing. So at the moment, we're not canceling it. We might cancel it, as I say, if things change and the hospitals get affected, we might cancel surgery. But at the moment, we are not cancelling surgery, and we're going ahead with surgery as planned. But If you don't feel comfortable, if you think, hold on a minute, I don't know what's going on. I don't want to go to a hospital. I don't want to be having surgery. I don't think there's any risks in particular with surgery and the coronavirus along those lines, but I understand you might not want to go to a hospital. There's other people there and what have you. I know that people worry about being around ill people and giving it to ill people. Private hospitals, by and large, don't have many ill people because it is sort of elective surgery. So most of the average length of stay, I don't know what it is, I should know, but for the whole hospital, maybe I shouldn't know. Why would I know the average length? But it's going to be a night, 2 nights, maybe 3 nights, probably not even 3. So people don't stay in the hospital for very long because it's usually planned surgery. So I wouldn't worry about that so much. But if you don't feel comfortable having surgery at this time, if you don't feel comfortable going out of the house at this time, then just postpone it. That's what I would say. And that's what I always say to people who are having elective surgery. So before this coronavirus blew up, if someone had a bit of a cold, if someone was feeling a bit under the weather, I say, look, 2 things. First of all, do you feel up to coming to have surgery whenever it is, today, next week? If you don't feel up to it, if you feel too rough, if you feel too tired, you're not up to it, then don't. You can be the ultimate judge of that. But if you do feel up to it, then you can come and we'll assess you and we'll make a judgment as to whether we can see you. So the anaesthetist would see you and assess your suitability for surgery. And it's the same thing with this. So if you don't feel up to it, or if you don't feel that the time is right and you think it's just too much in flux at the moment and you don't feel comfortable, cancel it. No problem at all. But if you do feel like you want to have surgery, then at the moment we're not cancelling cases. But we are very aware of the situation. I've spent all day sorting out virtual consultations, and we'll do as much remotely as we can. Can't do the surgery remotely quite yet, but we can certainly do a lot of the consultations remotely, and we're trying to be aware of what's going on and limiting contact. And at the moment, obviously, we can't do procedures and surgery remotely, so we are still doing that. But who knows? Not me, that's for sure. And goodness knows how it's changed in the last week. I don't know which way it'll go. It could go either way. And the chat is kicking off. Natalie, would it increase your chances of getting it? I said. Was that you, Natalie, last week? You said, would it increase your chance of getting it? Well, in fact, that you're going to, they say you shouldn't go to, well, it's America saying you shouldn't go to places more than 10 people, wasn't it? That was Donald Trump, but they shouldn't go to crowded places. Is a hospital a crowded place? I mean, it's at the moment, as I say, the moment that the guidance from the government is not to go to sort of places like pubs and restaurants and lots of people. I'm not sure where hospital stands on that. I mean, as I say, private hospitals have all got, I didn't say it, but private hospitals all got private rooms. There's not large groups of people. And going for an elective surgery at private hospital as it stands is not part of the guidance to not do, sort of thing. But I don't know. And I think, so the guidance is that you can still go out and do things like that. But whether that changes and whether you don't feel comfortable with it, then that's fine. Don't, it's really tough. Hi, Olivia. Good to see you here this evening. Natalie asked you in here. This is what I'm worried about, my surgery being cancelled. Yeah, I'm worried too. Olivia. I'm worried about cancelling people's surgery. We got a lot of people booked in for surgery, and I understand it's a massive event. It's a massive event in your life, in your, work, etc. And I don't want to cancel anything, and I won't cancel anything unless it's deemed not the right thing to do. I mean, we've got to look at the public health advice. So if the public health advice is that it's not right to continue doing elective surgery, and it'll probably be from the side of the medical side in terms of the hospitals using resources. I think that's what they're worried about, the hospitals using resources which the NHS might need, and whether we'll be asked to go and help in the NHS and what have you. That's been mooted that elective aesthetic surgery will be stopped, and then the doctors will be expected to help in the NHS. If it comes to that, then it might come to that, and it might get cancelled. Right now, today, as I say, we've done some surgery this afternoon, so we're not cancelling elective surgery. Tomorrow, this afternoon, this evening, will it change? I don't know. I don't know. We're just doing our best. We're just doing our best. Hey, JG, I'm booked in with you on the 31st. I'm hoping to still have it. Where do I stand if I have to self-isolate? Where do I stand? Well, in your room on your own, I guess. Well, you don't come if you have to self-isolate. It's like you had a flu. You wouldn't come in to have surgery with flu because you give it to everybody. I mean, maybe I shouldn't link it with flu because obviously it's a lot worse than that. But if you have to self-isolate, you have to cancel, Becky. And I think, I mean, the guidance is so, we've been trying to get through it. The guidance, I think you self-isolate for 7 days after symptoms, or 14 days if you've been in contact with someone with symptoms. So you just have to cancel, Becky, or postpone, rather, should I say. As the guidance is today, but the guidance, a week or a few days ago was like, if you've been in contact, not even a few days ago, it was yesterday or day before yesterday. If you've been in contact with people who have got symptoms, you could still carry on your daily life. But then the guidance changed yesterday to say if you've been in contact with people with symptoms, you should self-isolate, even if we don't know whether they've got the virus, they've just got symptoms. But so the advice is changing rapidly, Becky. But as it stands, if you have to self-isolate, you should self-isolate and not come to have your surgery, I'm afraid to say. Olivia, I don't want to cancel. I don't want you to cancel, Olivia. Tracy, hi, Jonathan. Danetta, brilliant guidance / advice. Look at that, Danetta, big fan. Thanks, Danetta. I'll give you a thumbs up if I could. Can't on this thing. How many people will be in the theatre at one time? Lol. So, good question. Groups of 10 people or more. Are there 10 people? There's probably getting on for 10 people in theatre, actually, Tracy. But the good news is we've got face masks. So you've got surgeon, scrub nurse, anaesthetist, ODA, who's a person who helps the anaesthetist, runner. So that's minimum. So runner meaning someone who gets the stuff. That's minimum 5. But, they could be up to 10. So it's a minimum 5. But yeah. But does that count as a crowded place, an operating theatre? We also have laminar flow in theatres where the airflow is controlled, and we wear face masks. But still, good point, Tracy. Good point. We don't want to give people coronavirus. Olivia, my bariatric appointment at York Hospital for Thursday was switched to a phone consultation. It's all. We're doing that ourselves, Olivia. We're going that way. Phone consultations, and who knows? Maybe we'll change for good. Because the other thing is the impact on the environment with the traveling. So we've got to try and look at the bright side of this. So if we will move more to I've been looking at obviously short-term solutions, but also long-term solutions in terms of virtual consultations and this sort of thing, and screen sharing so that I can still show PowerPoint presentations to patients. It's going to be obviously a bit awkward for the stuff that I do because I don't want really patients, demonstrating their issues maybe, but certainly we can go a long way to having advice, and I can do consultations and show slides online. But it's the way it's going, Olivia, and who knows, maybe this will be a force for good, that it will be doing less in-person consultations, and as I say, less impact on the environment in terms of cars and driving on the road, and it's always a CO2 emissions and things. Oh god, hold on, what's going on? Becky, financially, I mean, is it just a case of rescheduling? Booked in with, where do I stand if I have to self-isolate financially? Financially, do you mean we'll give you, if you've paid us some money, we'll give you the money back if you want to cancel, Becky, and if you want to reschedule, then that's fine. You just reschedule, and you just carries on. What do you need financially? What's the yeah? So whatever's right for you, Becky. if you no reason to at the moment. Yeah, no reason to at the moment. But if you feel uncomfortable with having surgery right now, then that's fine. I understand. It's a turbulent time. Turbulent time. Olivia, such a shame not seeing you in person tomorrow, though. JJ, I was really looking forward to seeing you. I spoke to the medical loan company today. Awesome, Olivia. Let's get it out there, Olivia. Olivia spoke to. I know, Olivia. I know, but we just got to do what everyone's saying we've got to do, which is limit people leaving the house and limit face-to-face interactions. So we're just trying to do the right thing, and that's what I've been trying to work on, getting all these virtual systems. But to be honest with you, at the end of the day, a phone, I think, if a phone's fine, but we're also virtual systems, what have you. But so it is big news, big news, and at this current point in time, as of today, we are carrying on, but we are looking, to be honest with you, we are the talk is of things being escalated, hospitals stop you doing elective work, so the talk is that things will be affected. I think we have to assume, what is it, prepare for the worst, which is hospitals being affected, work stopping, and hope for the best. But at the moment, we have to prepare for the potential for hospitals stopping operating. And as I say, as doctors, we will do what we need to do and help in the NHS if needed, or help in the private sector with people if there's going to be these sort of mass casualties that are predicted, or potentially predicted if we don't do this stuff that we're doing now. I guess if we do this stuff now properly, the self-isolating and the virtual consultations, which yours truly was doing the virtual stuff quite some time, and now look how professional I am at it. In fact, I've seen people doing it a lot, and they don't have big microphones standing in front of them. Can I put the microphone down, do you think? Whatever, do I put the microphone down? How's that? See if we get even more professional. Right. Okay, that. Can you hear me all right? Has the audio suffered? So, steady on. Chat's kicking off. Sherilyn, hope things get better soon. So do I, Sherilyn. So do I. I really do. Angela says, hi. I've had it done. Went in Thursday, out Saturday, feeling fantastic. Yes, you threw it, Angela. Through it. You got through the line. You got through past the line before it all kicked off. Awesome. That's the way to do it. Is it all right having the microphone there then? Is that all right? Do I not have to hold it? Audio is fine. Okay. Been holding it all this time. The professionalism never ends on this. We're constantly getting more and more professional and slick on this. Look at that. To the extent that look at that. Oh God, messed it up. Anyway, right. It's going so well. So surgery after Accutane. How long do I need to wait to have surgery? I've recently completed a course of Accutane treatment. I was advised to wait 12 months before having surgery. What are your views, and can you explain why this is? So this patient is this person has seen someone who has said they have to wait 12 months, and they don't want to wait 12 months after the Accutane, so then has got in touch. And to be honest with you, this isn't my niche. This isn't my forte. This is more of a thing that would be down to the doctor who prescribed the Accutane. But the advice is to wait for 6 months after stopping Accutane. I mean, you've been told 12 months. I don't know. I'm not an expert in the field, but it affects wound healing. That's the problem. So you should really avoid surgery for a period of time after stopping Accutane, which is a drug used for skin problems, and it can affect healing of wounds because we cause wounds. And I think it's like an it dampens down inflammation, which is obviously important when you have bad skin, but inflammation is an important part of wound healing because a wound heals by the same processes of inflammation. That's my armchair knowledge of Accutane. I'm not an expert. You need to talk to someone who prescribes it and uses it. And that's what I would do. I would talk to your doctor who's prescribed the Accutane to say, what do you recommend? But the general advice is 6 months. So, I would at least 6 months, and 12 months is not unreasonable. And it's probably best to ask your physician who prescribed the Accutane why this is. But from a plastic surgery point of view, it's a wound healing issue with the Accutane. So you are better off waiting. So I'm sorry if you obviously want to have surgery done soon, but it's no good if your wounds aren't going to heal up properly. So, and obviously the Accutane, well, hopefully the Accutane was used for a reason and was a good thing to have, and hopefully that's done the job. So look on the bright side, I suppose, if you can. Try and look on the bright side if you can. Angela did it. Amazing. I did it. Shut Saturday afternoon. The hospital did. Nice one, Angela. You got in there. Awesome. Someone's looking down on you. Can you go overs? Also, what is the maximum size you would go to for a BA with plenty of room for bigger implants? So a bit of a wide, well, bit of a wide question. The second part, the first part is relatively easy. Can you go from unders to overs? Yes. The only thing for this, so for those of you who don't know the chat, the slang. Unders means under the muscle, overs means over the muscle. I don't know if that's obvious or not. But, so can you go from putting the implant underneath the muscle to putting the implant over the muscle? Yes. And vice versa. You can go from putting the implant over the muscle to muscle. The thing that I would slightly worry a bit about the question when someone says, I want to go from unders to overs, I'm sort of thinking, why did you have it under? Now, so the thing about unders and overs, and I think I've got another question in a minute about this. There's pros and cons of putting it under the muscle and pros and cons of putting it over the muscle. And broadly speaking, the worry is that you are going to see rippling, feel the implant, have palpable edges, see visible rippling of the implant. If you put it on top of the muscle in someone who is very slim, and sort of my ballpark feeling about that is if I can see your ribs, if I can see your rib cage, I'm thinking, I'm probably going to be able to see that implant. So I want to put it under the muscle. So in patients who are very slim, you put it under the muscle being the pec major muscle, to give it a bit of cover to hide the implant, so you're less likely to see those ripples of the implant, because all implants ripple a bit. And the question is whether you can see those ripples. So that is the good thing about putting them under the muscle. But if it was all good, we would just put them all under the muscle. You'd always put them under muscle because, no one wants to be able to see the ripples. So there's not obviously, but there are bad things with under the muscle. So it hurts more, bleeds more, recovery slower. But also the main things are the implant can sometimes sit high when they're under the muscle. The muscles can sometimes hold the implants high, sometimes hold the implants wide, and sometimes you get animation deformity. So if you do the gym, if you do a lot of exercise, the implant moves when your arm moves. So those are the bad things about putting them under muscle. So the reading between the lines with this question, I'm sort of thinking this patient's probably got a problem with them under the muscle because she wants to go from unders to overs. She's probably got a problem. So she's maybe got, and I don't know if you're out there. If you're out there, chip in, let us know. But I understand if you don't want to. So you might have animation deformity. You might have very wide cleavage. You might have the implant sitting high. So you might have a problem with them under the muscle. So you might be thinking, I know what, I don't like this problem. I'm going to put them on top of the muscle. The problem with putting them on the top of the muscle is I'm thinking, why did they put them under the muscle in the first place? Were they worried you were going to get rippling? See the edges, feel the edges. Because presumably you're slim. I don't know. Usually people who have it on the muscle are slim. Unless you put on loads of weight and you were very unhappy with your weight before and you put on weight and you've got a much better coverage over your chest and you can't see your ribs anymore. So if you're not slim so much now, then maybe fine. But if you are still slim and I would worry about changing from under to over because you might be curing one problem but creating other problems. So you might be able to see the implants, feel the edges, and what have you. So that worries me. I less worry about the other way around. So when people go from over to under, so usually, well, not usually, but if you're going to change plane, that's probably a more common thing. You have them over the muscle, you get rippling, you can see the edges, looks, don't like the look of it. So then you can go under. That's a sort of more normal way to go from overs to unders. It's less normal to go from unders to overs because you went under for a reason. And if you then go over, there might be signs of rippling. That's one thing. First, number two is what is the maximum size you would go to for a second BA with plenty of room for bigger implants? It's based on the width. So basically, the width is the number one measurement that I work on when I look at someone who's having breast implants. So I measure the base width of your breast, and you want to go a bit in board of that, a bit less than the base width of the breast. And then you look at the shape and profile. So if you're out right, what's the biggest I could? Well, the biggest you could have is an extra high profile round implant. So basically, round implants carry with them more volume than a teardrop implant of the same width. So if you want bigger, round is bigger for the same width. As I say, the width is set. And then when you've got that width, if you're having round implants, you can have low, moderate, high, extra high profile. They get progressively fuller, progressively rounder for the same width. So the biggest implant for the width would be an extra high profile round implant. And the actual would depend on the width of your breast. So I can't tell you that without seeing you and measuring you. But that's how I would go about if you wanted the absolute biggest you could have. But the extra high profile does give a fuller look, which you might be happy with, but it's a fuller look. It's what it is. It's what it is. One word. Seroma. Seroma. Once you've had one and it's drained a lot, 7 large syringes full, why has it within 48 hours come back? And will it keep happening? When does it stop? I've adhered to all the rules and worn compression 24/7, yet it came back. Well, yeah, I'm not surprised. I'm sorry to say I'm not surprised. Seroma is not a common problem. It's not common, but it can be a problem. It's not like it's wow, that's really rare. It is definitely out there, and it's there when you're doing particularly things like tummy tucks. Well, actually, tummy tucks particularly, but places where there's a space, surgery when there's a space. Because when you make a space, and with a tummy tuck, you have to make a space in order to close the wound. In order to get the top flap down, you have to make a tunnel going up the middle, sort of release the skin off the abdominal wall so that it can pull down. Whenever there's a space, that space can fill up with wound fluid, which is basically what seroma is. It's serous fluid, which is that yellowy, sort of watery, hay coloured, is hay a colour? Hay coloured fluid. Yellow, call it yellow fluid, which is serous fluid, wound fluid. And the problem with seroma is that what you want when you create those flaps and you bring it down, and you want it to stick down. That's why you have some, often we use these suction drains, which there's a continuous negative pressure, continuous sucking. We put you in a binder, sort of trying to suck those two sort of space, those two skin, those two flaps together to close the dead space. But the problem is, and that's what happens the majority of the time, if it doesn't suck together and you get a bit of fluid there, if you get a bit of fluid there, then you've sort of lost the sucking together moment. It's a bit like, is it a bit like this? Is this a good analogy? When you glue a couple of things together, or you got some adhesive, and then it shears a bit and a bit bubbles up, and you try and stick it down again. Never sticks so well, does it? I don't know if that's an analogy or that, but anyway, basically it doesn't stick down again as well. So what happens is you drain it. It's relatively simple to drain it, but the space is still there, and another seroma comes pretty quickly after the first, if when it's not. So we drain it, and like you said, you're doing this compression and all that sort of stuff. We wear the compression, but once you get a seroma, it's pretty. I'll say always. It's sort of certainly more common than not. So it's pretty much always will come back. The hope is it comes back less than before, and if you can bear with it, then bear with it and just go with the binder and time. But if you can't bear with it, then you might have to have it drained again, and then it can come back again, and then you can have it drained again. And the other problem is that when you're having it drained, there's a very small risk of introducing infection. So I always say to people, don't have it drained just for the sake of draining it. Have it drained when it's sort of uncomfortable and when it's bothering you, because hopefully it'll take longer and longer periods between the draining, because you don't have to come back every few days and have it drained. So the longer you can leave it, the better. And it does tend to tamponade itself, which means that it quite rapidly fills, but then it gets to a certain pressure and then it doesn't keep on filling. So if you sort of had a seroma and then you maybe had it drained and had, I don't know, 100 mils or something, or 200 mils, or let's say 100 round figures mils, and then 3 days later you came back, said, oh, it's come back, and they drained it again and there's another 100 mils. What would have probably happened if you'd left that 5 days or 6 days? There'd have been 120 mils. There wouldn't have been 200 mils if you'd left it another 3 days. So the first 3 days is 100 mils, but then it goes like that, it plateaus. So your first 3 days is 100 mils, but then there's less every time because it tamponades, it gets pressure. It tamponades itself, and it doesn't, it gets less and less. So it wouldn't be another, you don't think, oh God, that's 3 days and I've got 100 mils. I better get it drained every 3 days, because if I leave it 9 days, I'll have 300 mils. Oh my God. Leave it 12 days, and 400 mils. It doesn't work like that. Leave it 9 days, you have 150 mils. Just have a bit less, a bit more. So it does keep on. They are a nuisance. They are a nuisance when they come. And the trick is just to try and be positive, try and stay with it, and carry on doing what they're telling you to do in terms of compression and what have you. And when it's uncomfortable, when it's symptomatic, have it drained, and it should stop. But it is, sometimes it's not too bad. But if you just had one, once you've had one and it's drained, why has it within 70 hours come back? And will it keep happening? Yeah. So you haven't had many. Yeah, it will keep happening, but hopefully it keeps happening less and less. So you get to the stage where you don't need to have it drained anymore. So you might be there already. You might only have one drainage, but sometimes you need more than one. Recovery with implants and lift. Sorry, it's all mirrored. It's hard. This recovery with implants and lift. Under or over muscle in breast implants. Comparative pain / recovery / appearance. Also, when combined with the breast lift? ? That's a big question. A lot to cover there. Under or over the muscle in breast implants? Well, again, like I said earlier, pros and cons on both. But broadly speaking, if you're very slim, if you can see your rib cage, you worry about being able to see the implant. I should have some props, shouldn't I? I've got an implant in here somewhere. What's that? Hide the stash of implants in case it falls into the wrong hands. But anyway, basically, if you hold an implant up, you can see the ripples. I'm going to have a quick look. You all right? You all right for a minute? I'm back. It's okay. Sorry about that. So here's an implant. I found one. Here's an implant. So if you hold an implant up, you see the ripples. So they all basically ripple when they're in the body. That's a physical attribute of the silicone. That's the fact that they're squidgy. Now they are less squidgy than the old ones. The old ones are more squidgy. less cohesive in terms of medical terms, but the old ones were much softer, which felt softer. These feel a bit firmer than the old ones, but they're safer if they rupture because the gel is more firm, so they don't leak liquid silicone. But still, all implants to a greater or lesser degree will ripple inside the body, and the question is whether you can see the ripples. Simple as that. So that depends on how much cover you've got. So as I say, if you can see your ribs, then you can see your um, you worry that you're going to be able to see the implant. So that's where you'd have it under the muscle. But pain slash recovery slash appearance. So pain and recovery is going to be worse with under the muscle, more painful, longer recovery, bleeds more risk of hematoma. When I talk to people about recovery after breast implants, I say the same thing where they're having it under or over the muscle. So first week you're not going to feel like much. Second week you're going to feel better. Maybe start driving and what have you after the second week, and 4 to 6 weeks for anything with your upper body. After 2 weeks you'll be doing lower body stuff at the gym. Are we allowed at the gym? We're going to cancel my gym membership. Should I just cancel it? I'm not supposed to go to the gym, are we? Only just started going to the gym. Anyway, mind you, I lost my shoes, so I've been going for a while anyway. But so yeah, after a couple of weeks you can do the gym, lower body stuff, and then 4 to 6 weeks for upper body. So I say the same whether it's under or over the muscle, but it's just broadly speaking a bit worse if it's under the muscle. But having said that, I do have patients who've had it under the muscle and haven't had pain at all, and they're like, I don't know what all the fuss is about. It's fine. And similarly, I have had pain who's had it. People who've had it over the muscle who've had a lot of pain. So there is a overlap. Broadly speaking, a bit worse with under the muscle. Appearance, really interesting question. Appearance, I find this really interesting because I get a lot of people who come to me and say, "Oh, it's more natural. It's more natural under the muscle, isn't it?" Or have this view that I'm like, most people want it natural, and it's not. If you have it under the muscle, if you're very slim and you have it under the muscle, it's more natural because you won't get rippling, because rippling is not natural. So that means it's more natural if you have it under the muscle. But if the muscle holds it high or holds them wide, or you get animation deformities, it's less natural. So in those circumstances, you'd have been better off having it on top of the muscle. It's more natural on top of the muscle because it won't be high or wide or animation deformities. So you can have a situation where it'd be more natural having it on top of the muscle, and you can have a situation where it'd be more natural having it underneath the muscle. So basically, you've got to have what's right for you, and you've got to balance the risks. There's a risk it could look unnatural having it over or under, and you've got to balance the risks to maximize your chances of it looking natural. Sorry, maybe I need to write this down and make that a bit clearer. I don't know if I've made that clear, but basically, it's not true that it looks more natural under the muscle necessarily. There are situations where it does look more natural under the muscle, but there are also situations where it will look more natural on top of the muscle, because you can have it looking unnatural under the muscle. Just kidding. Oh God! Did you get my? Is anyone following this? I don't know why it's all coronavirus, isn't it? No one cares about this anymore. It's all corona. No one cares about under the nuts. Anyway, I know why. It's all there. It's all there. It's just getting it out. It's conveying it. Anyway, that's maybe ask me again. I'll do it. Try it next week. Try and answer the question better next week. Anyway, also second part, two-part question. This also when combined with a breast lift, when combined with a breast uplift. I think that means when. Well, I don't know what it does. It mean when would you combine it with a breast lift, or what's the recovery when combined with a breast lift? Anyway, basically, a breast lift makes things worse, more uncomfortable. A breast lift with implants is a big deal. A breast lift with implants is a big op. It's many good surgeons don't do it in one op. They stage it because it is such a big op. Because a breast lift tightens the skin. That's how a lift works. And then implants tighten the skin again. So there's a high risk of wound healing problems, complications, infection. If the infection gets to the implant, you have to remove the implant. So there are risks in doing a breast lift with implant. So I think is this question maybe when combined, when would you combine it with an implant? So when would you do it? You would do it if broadly you got your shape and your size. Lift's good with shape, doesn't really do anything to size. Implants good with size, doesn't really do anything to shape. So you would combine a breast lift with implants if it's the shape and the size you're not happy with, meaning your breasts are sitting low and they're too small. If one is an overriding problem, you could just have one. So if your breasts are sitting a bit low, a bit saggy, feel a bit droopy, but you wear a C cup bra or a D cup bra or a double D cup bra, and you're actually happy wearing that size of bra, but you feel like when you take your bra off, they descend, then maybe a lift would be all that you need. However, if it's mainly size you don't like, if they're small but they're looking a bit droopy and you think they need to be fuller but also bigger, there might be a situation where you could just have implants and not have a lift, although it wouldn't lift your nipple. Your nipple would still be sitting low, but you would have volume, and in a bra you might feel good. So there might be situations where you could have one or the other. But if the breasts are sitting low and you want them bigger and lifted, that's when you combine a breast lift and implants. Oh, look, Olivia's following. Someone's following. Thank you, Olivia. You're making notes, drawing an algorithm. I have to reflect on this and see how I can say it a bit clearer. Thank you, Olivia. Thank you for that support. Natalie, I'm just going to say Natalie. I think you just say Natalie. I think you said once you just say Natalie. So I hope that's all right. I'm just going to say Natalie. I'm with you. Just depends on the person. We are all different. What works for one will not work with another. Yes, Natalie and Olivia are with me. Thank you, people. We are 3. Hold on a minute. And Tracy, we are 4. Yes, there's 4 of us who are following this. Excellent. Here we go. Olivia, say I don't see you in person before the surgery. How do we make the final decision on over or under, etc.? Well, Olivia, I've seen you already, so I've got a view on it, and we chat, we rap, and I can see you in person, Olivia. That's the thing about this virtual thing. We'll do the virtual um, consultations, what have you, and see how that goes. But it doesn't mean that we won't do any more face-to-face consultations. We'll still do face-to-face consultations, but it's just the advice at the moment is to limit things. Maybe they'll slacken off and we'll be doing more face-to-face, but it depends, Olivia. If we might be able to make a decision without an in-person consultation because you've already had one. I think is a bit different for people who've not had an in-person consultation. I feel a bit uneasy about doing that without someone who's never had an in-person one. I think we can do initial consultations in a virtual way, and I've got a couple tomorrow. But I think if you do go ahead and have surgery, I think it is good to come to clinic and have an in-person one prior to surgery. But that's different for you, Olivia, because you've been already. That's my question. So yes, I'm having implants and lift together and thighs all in one operation. Yeah, I know it is, Olivia. I know. I didn't want to say anything, Olivia. I'm trying to keep a bit of keep it subtle. But yeah, I hope that answered your question. Olivia has got 4 lots of thumbs up. Wow. That's 2 people with both hands up. Whoa. And just so everyone knows, Olivia's away working till April the 14th. Okay. Surgery on the 24th. It's a busy, busy time, Olivia. It's a busy time. I tell you what, Olivia, what do you mean you're away? Are you away? No one's going away anymore. Everyone's staying at home. You're allowed to go away. Who knows what's going to happen? Right, people. I've got a full disclosure here. This is the last question. Hold on a minute. I haven't written it down properly. Oh, Durham. You go to Durham. Okay. So maybe you will be allowed to go to Durham. I don't think they've closed the borders of Durham yet. No. Durham borders are open. Okay. Right. Can I ask for a revision? Lisa, you missed the start. Lisa, what are you playing at? Come on. No excuses. Honestly, you didn't miss anything, Lisa. Oh, it's just doom and gloom about the corona. Whoa, lights on. Right. Sorry, I've cut the end off this question. So this question was, Lisa, we're on the last question. I've got to be honest with you. I don't want to ruin your day or anything, but you know what? It comes on. You can just click. You can replay it, can't you? You don't get the full immersive experience of the live, but still you can you can try and relive it at your leisure at home. So, sorry, hi, sorry to bother you again, yet again. I'm 7 months post-op with full tummy tuck, lipo to flanks. Nothing has changed. In your professional opinion, in my next appointment with my surgeon, what should I not leave without him fixing? I'm so unhappy with the outcome, in my opinion. Still have so much fat and um, skin left. I'm not flat and tight when I stand up. My scar is so high you can see it at the front of my boxers that I have to wear now to hide the scar. I have a random stitch which is now a dent. When asked why, was told it's just a stitch, but you can really see it. Full on ledge, dog ears, and my left dog ear is really tight. When I bend over, it feels like it's pulling. Am I within my right to ask for all this to be addressed? Really been an emotional ride. Thanks. Oh dear. Tricky, isn't it? I've got to get involved with someone else's thing. I mean, this lady sent photos as well, so I've seen photos of the result, and I gotta be honest. I think I just want to give you the view from the doctor's view, because I do believe that we are all trying to have happy patients, and we value a happy patient. I mean, I certainly am very aware of the value of a happy patient, and will go to great lengths to ensure that patients are as happy as I can possibly make them, and will do. And I think most doctors will do whatever whatever they can to make patients happy. We're not trying to get out of stuff. I don't know if I should speak for everybody, because I think that's true. I don't think we're trying to get out of doing things, and I will maybe do a bit of a revision, a bit of this and that, even if I think, oh, don't really need it. But I want the patient to know that I'm on their side, and I'm trying my best to make everything just the way they want it. So the question is asked in a little bit of a slightly confrontational way, like, what should I not leave without, what is it? Should I not leave without him? What should I not leave without him fixing? It's like saying, I'm not leaving until you fix my dog ear. It's like, I don't know. I think we are trying to help. Most of us are, slash all of us. And so I think we are trying to do the best for you. And I think you should try and maybe get more of a mindset of, like, we're on the same side. We're trying to give you the result you want genuinely, because it's very damaging having an unhappy patient. If you have an unhappy patient out there in this day and age with social media, internet, you know God knows what, and then you start saying, I had this surgeon and he did a dog ear and it all pulls in and it didn't fix it and it looks awful and I'm very unhappy and I've got ledge and this and that. That's worth a lot in a negative way. So the flip side is, you would go a long way to turn that patient into a happy patient if you can, particularly if it's just a question of doing a bit of revision here or there, a bit of a tidy up maybe. So that's what I would say as a general principle. And so it might not be that the surgeon's being evasive, which is what I'm feeling that you're portraying. You feel that you're being not listened to, which I think is, I think that's a problem with doctors. Actually, I think we need to convey this sort of stuff to patients, and we need to convey that we are looking after them, or we will do whatever needs to be done. I talk to other doctors about this stuff, and I think, and this probably hasn't been conveyed very clearly to you, if that is what the doctor does feel, which I hope they would feel. So 7 months post-op is not a huge amount of time. Things start to settle around 3, 6, 12, even 18 months for it to fully settle. And looking at your photos, I think there is some swelling going on there still, and I think there is some room for improvement. And you say I've got a random stitch, which is now a dent. When asked, was told it was a stitch, but can really see it. In terms of tummy tucks, we do use some long-term dissolving sutures, and they can tell they when you look at the sort of packet, when you don't look at the packet, but if you look at the sort of information about the sutures, it will say it takes 1 month to dissolve or 2 months to dissolve. You might say, I'm 7 months in. What are you talking about, you crazy man? When they tell you how long it takes for the stitch to dissolve, they're talking about the tube stitch being surrounded by water. They dissolve by being surrounded by water. Water's inside your body. And so a tube of a stitch might take 1 or 2 months to dissolve. But when you've got a knot, only the outside is in contact with water. So it takes a lot longer for the knots to dissolve. That's why at the ends of the wounds, you often have problems because there's big knots there. And along the wounds with tummy tucks, we put lots of knots along there. So knots can take a long time to dissolve. So if you have a dent, sometimes you do have a dent because we put some deep sutures to hold everything together, and that might be denting the skin in a bit. But that suture will dissolve in time. So I don't think that's anything particularly to worry about. Similarly, dog ears are made worse by swelling, and so there might still be some swelling there. And one of the problems, I think, psychologically, you get into a situation where you feel like you've got all these bad things and they need to be fixed, and you start just focusing on looking on the negatives. And a lot of your photos, you were sat forward, you were sat, um, and I understand that it's obviously worse when you sit and when you bend forward, but everyone's is worse when they sit and they bend forward. Now, yes, you did show some photos of you standing up straight, and there was a bit of swelling there when you're standing up straight. But I think because you become fixated on it and you start bending forward and say, look, I've got all this big lot here left behind. And, you need a bit left behind when you bend forward so that you're able to stand straight. If you make it really tight when you bend forward, you're not going to be able to stand straight. Now, when you first saw it, tummy tuck, it is like that. But, I think, the scar's high. The scar is often high. It's hard to lower a scar, number one. And number two, it might settle over time. And I know 7 months you might think, oh, pulling my chain. I've got no vested interest I don't know anything about your treatment or anything. I've got nothing to do with it. So, honestly, it can take, I've got a photo I show in my slide deck, which is one at 8 months and 16 months and how it settles. I could probably show it, couldn't I? I'll keep talking. So it does take a long time, or at least it can take a long time for everything to properly settle. And I would work with your surgeon, and no, don't go in there trying to make demands and say, I'm not leaving until I've had this done. I would hope he or she would be wanting to give you a good result. And if he or she feels that there's still some swelling to go and thinks that there will be improvements over time, it might be worth waiting to let those improvements get maximally as good as they're going to get, because you don't really want to have one revision and another revision. You don't really want to have one dog ear now and then another dog ear later. You want to get one revision, and so really around a year and maybe even more. I'll show you this one if I can, for it to really properly settle. So I think try and get on side with your surgeon. Try and accept that there might be some improvements still to come, because everyone's different, and sometimes people at 3, 4, 5, 6 months have all settled really well. Sometimes people at 7, 8, 9 months are still quite swollen, scars still quite red, scars a bit pulled up, and what have you. Everybody's different, and a bit of positivity. Try and keep the faith, and hopefully everything will be all right, in the words of Bob Marley. Right, let's have it. Right, now we're going techno, because this is the sort of techno wizardry you get on this show. What you're going to have before your eyes, I know I've done this before. What I'm going to do, quite simply, people, is, yes, you know what I'm going to do? You know it. I'm going to share my screen. Yeah, you heard me. I'm going to share my screen. So, I don't know what's going to happen to the audio. I'm going to do it. I am going to Chrome tab. So share. Can you see that? Can you see that? Oh dear, oh dear. Anyway, I am going to share it because I am a pro and I've been doing this for years, guys. You get someone who just fly by night who just started, they won't be as slick as this. Okay, so maybe not sharing it as well, but it's a start. Shared screen. Okay. Don't get this slick work anywhere else, do you? You know, he knows what he's doing. Knows what he's doing and just gets it done. Simple as that. Gets it done. Okay, can you see that? That's how we do things around here. Look at that. So you see, oh, I can't, can I point? Come on, man, you're asking too much to point. Anyway, 8 months, still quite red, still quite pulled up. 16 months. Now, I think he's put on a bit of weight. So he hasn't had liposuction to the sides, but that's a different story. And he's put on a bit of weight. But 16 months, and it's sort of settled, dropped down a bit, and the scar has settled. So look at that, 8 months. And you might be unhappy at 8 months and think, oh, this scar's quite red and quite pulled up. And 16 months, and it has settled. Now, it's not always like that. It's not. It doesn't always take that long for it to settle, but it can take that long for it to settle. It is not unusual for it to take a year or more for the scars and swellings and bits and bobs to settle. So, in answer to your question, yes, you can ask for a revision. It's your body, you're the patient, you're the ultimate judge of your result, and not us. We have to, but our job is to say what the right way of treating your problems are. So your job is to say what your problems are, and we've got to try and give you the best advice we can in terms of how to treat those problems. And it might be that waiting and letting the scarring and to soften and settle would be the best way to treat that. It's not fobbing you off. It's not trying to get away with it. The only problem you've got to watch out for actually is if they've got a revision policy at a certain time and they don't, because I've heard of people like that. They say, 5 months, oh, leave it for a couple of months, and then at 8 months, oh, we've got a 6 month revision policy you have to pay now. That's bad. But so just look out for that. But you can ask for a revision, but it might be that leaving it might be better to let things settle. But I'm not your surgeon, so best to check with your surgeon. Chat's kicking off. Natalie's in Sunderland. Congratulations. I hope everything's good there. Lisa, yes, you did miss your question, Lisa. You have to work out which one Lisa's was, somewhere up there or back there. I answered it very well, by the way, Lisa. I think you'll be pleased. I'm getting on the train regardless. Money calls. That's the spirit, Olivia. None of the public health worries. Getting on the train regardless. Money calls. Yeah, that's what I'm talking about. I'm freaking out that it may be postponed, Khan. I had a cereal binge this afternoon. What's a cereal binge? Don't freak out, Olivia. Don't freak out. Stay calm. Thanks so much, JJ. You've made me feel so much better tonight. Oh, wow. Have I? Blimey. How did I manage that? Marie Louise Lynn. Oh, look at that. Marie Louise has come in with a question. Nice. What damage is left after a large hematoma above the TT scar? No damage, I would say, Louise. Hematomas are good. Thank you, first of all, for the question. Thank you very much. Hematomas are horrible because you have to go out to theatre and you've just had an anesthetic and you have another anesthetic and it really knocks you back and it's really not nice. But they don't tend to leave long-term damage. The short term, yes. So it might take a bit longer for the scarring to settle. There might be a bit more swelling because obviously you've had the scar open twice and you've had to have it washed out. So that can be quite traumatic. So it might take a little bit longer for it to settle. But after a year or 18 months, it should be no different to how it would have been if you'd not had the hematoma. So you shouldn't have any long-term damage, Marie Louise. I'm sorry to hear that you had a hematoma, but you should be able to um, not have any different result than if you hadn't had it, apart from the fact that you've had to have two anesthetics, which is unfortunate. So I hope that has covered that for another night. And what a difference from last week to this week. Who knows what is going to be happening next week? I'm going to look back at this week's advice that I've given you and say, look, everything I was wrong because now coronavirus has stepped into this phase or that phase, or now we're back to normal and everything's back. And goodness me, do you remember last week we were worried about it? I hope that's what I'm going to be saying, but who knows? Hopefully everything will be fine, and a bit of positivity is called for. So thank you all so much for wonderful interaction, wonderful questions. And Lisa, I hope you can find your question back there. And I think you will find that it has been comprehensively answered by yours truly. And if anyone has any questions, please feel free to comment somewhere, or message me, or email me, or do whatever you want to do to me. And I will do my best to answer it in spectacular fashion. And here's to virtual consultations and not driving around so much. And I'll see you next week, same time, same place, Tuesday, whatever next week is, 24th of March, 7 p.m. I will see you there. But for now, I'm checking out. Nighty night.